Dear co-chairmans, dear colleagues, unfortunately, I have a little time for my presentation, but I'll try to be in time. In previous session, session 1, our speaker said about predictors of efficacy, and my task, my presentation, generalize it. Predictors should assist physician and patient in decision-making concerning whether to start and on which regimen, and whether to stop and whether to modify the regimen. There are pre-treatment and on-treatment predictors. Pre-treatment predictors include viral factors such as genotype, subtype of virus, viral load, and some mutation in different regions of ACV. Host factors include mainly interleukin-20AB polymorphism and other sex, age, overweight, insulin-resistant, alcohol, ethnicity. Disease-related factors include main factors as a cirrhosis and fibrosis state, of course pattern of previous non-response, and other co-infection, organ transplant. Treatment-related factors include on-treatment response, AVIA, lead-in phase, EVIA, GVIA, low dose and short duration, low tolerability and adverse events, and low adherence. Main baseline characteristic influence treatment outcomes. For example, easy to treat, for example, treatment-naive patients with genotype 2, with genotype CC, interleukin-28, and mild fibrosis. Too difficult to treat patients, for example, genotype 1A, CT subtype, cirrhosis, and maybe DA failure. Using dual therapy with PEG and RIBA, AVIA was stronger than all baseline predictors of SVR using PEG and RIBA. Why identify predictors of efficacy for triple therapy with boceprevir and tenofovir? There are some advantages and disadvantages. Advantages include PI substantially increase SVR rates, successful treatment improves liver-related morbidity and mortality, and potential for shorter treatment duration. Disadvantages include increased side effects and toxicity burden, low SVR in difficult-to-treat patients, cirrhosis and null responders, but cost. Triple therapy requires investment of medical and economic resources. Then, when we ask why identify predictors of efficacy for triple therapy with boceprevir and tenofovir, we may answer to avoid or reduce lack of resources and useless side effects in patients. On the slide, you can see total SVR rates with boceprevir or tenofovir, PEG, RIBA, according to treatment history. It's very interesting. Patients with relapses to dual therapy with PEG and RIBA had higher SVR rate than treatment-naive patients. Maybe successful continue lead-in phase is favorable predictors of high SVR rates. As for interleukin-28B, CC genotype predict likelihood of achieving SVR in treatment-naive patients, similar as a dual therapy. Moreover, CC genotype predicts likelihood of eligibility for shortened therapy, so more than 80% of patients can be treated no longer 6 months. Finally, the last trials demonstrated highest SVR rate in treatment-naive patients with CC genotype after short course of triple therapy, only 12 weeks with tenofovir, PEG and RIBA. That's why interleukin-28B genotype should not be used to exclude patients from therapy, especially in treatment-naive patients, because if patients has favorable CC genotype, likelihood of SVR is high with PEG and RIBA alone, but triple therapy may allow shorter therapy, and in one tenofovir study, high SVR rates. If patients have unfavorable genotype, likelihood of SVR is higher with triple therapy than dual therapy. And there are limited value of interleukin-28B in treatment-experienced patients because most of them have unfavorable genotype. Next important predictors, fibrosis state and cirrhosis. On the slide, you can see limited data and lower SVR rates with advanced fibrosis in treatment-naive patients. This column. In real-life study, previous relapses with cirrhosis had high SVR rate compared with low and very low SVR in cirrhotic previous null responders and partial responders. This is total result from SPRINT 2 study, and significant influence of male baseline patient and virus factors on SVR with boceprevir concerning genotype 1b versus 1a, high and low viral load, mild and advanced fibrosis, and interleukin-28B polymorphism. Similar results were received in advanced study with tenofovir. Genotype, ACV, viral load, fibrosis state, interleukin-28B. On treatment predictors, likelihood of SVR according to viral response in the first weeks of dual therapy was demonstrated some time ago. On the slide you can see the likelihood of SVR is directly proportional to the time AVIA, week 4, EVIA, 12 week, and DVIA, 28 week, of ACV RNA disappearance. Similar results were received for triple therapy. SVR for early and late viral responders with boceprevir and tenofovir was significantly different. Graphically, you look for boceprevir, AVR, week 8, undetectable, detectable ACV RNA, and for tenofovir, extended AVR, week 12, yes or no. Furthermore, in SPRINT 1 study, patients who had lead-in phase had significantly higher IVR rates than patients without lead-in phase. However, there are no significant differences according to SVR by lead-in phase. In next SPRINT 2 study, higher SVR was in all patients with IVR. SPRINT 2 in response to combined results demonstrated that early interferon response, lead-in, these patients who are responsive to interferon after lead-in, more than 1 log decline ACV RNA, further defined likelihood of SVR even in patients with unfavorable CT and TT genotype than patients who poor responsive to interferon after lead-in, less than 1 log decline of ACV RNA. In PROVIDE and REALIZE study, there are significant differences between patients with responsive to interferon and treatment-experienced patients after lead-in and patients with poor responsive to interferon. Moreover, patients with relapse, partial L null response had high SVR rates and with the decrease of viral load more than 1 log after lead-in than patients with poor responsive to interferon after lead-in, less than 1 log decline. Similar results were received for patients with cirrhosis. You see, both treatment-naive and treatment-experienced patients with cirrhosis had high SVR rate if such patients was responsive to interferon after lead-in. Compare with the patients with poor responsive to interferon after lead-in. Important predictive value of week 8 response to boceprevir was SVR in poorly interferon responsive patients. Among these patients, nobody with less than 3 log decline in a severe RNA at week 8 of therapy achieved SVR. Thus, lead-in strategy can help determine whom to treat. 4 weeks of PEG and RIBA, lead-in before boceprevir or tenofovir, lowest SVR RNA burden, may identify rapid responders who may not need DA, provides useful information regarding likelihood of SVR with addition of DA, provide insights into tolerability of PEG and RIBA backbone, and elucidate hematologic response to PEG and RIBA, especially in marginal patients, make needed dose adjustment before addition of DAA. What are my chances of being cured with current therapy? You look favorable and less favorable prognostic factors. How will we use all the new predictors in a new DAA combinations, especially in interferon-free regimens? What's the role of such predictors and new DAA combinations? You look interferon-free, dual therapy, sofosbuvir and riba, atomic study results, viral kinetics by ACV genotype and interleukin 28B. Similar viral dynamics regardless of genotype. There are no significant difference between genotype 1A and genotype 1B, and according interleukin 20AB polymorphism. Next study, Pillar Aspire. This is new PI simiprevir. It's a second wave of first generation of this drug with PEG and RIBA in patients with genotype 1 ACV and advanced fibrosis. Subanalysis from the trials revealed relatively high SVR24 rates in patients with advanced fibrosis, both treatment-naive and experienced patients. Moreover, there are no significant differences between relapses and partial responses, and high SVR rates, 31%, for cirrhotic null responders. Next, Matterhorn study respond to quadratherapy with PEG and RIBA and protease inhibitor danaprevir, bastit, ritonavir, and polymerase inhibitor mericitabine. You see high response rate, highest with 4 drug therapy, both prior partial response and null response. However, high response with PEG interferon containing regimens was in genotype 1B, compare with genotype 1A. Of course, all null responders have 100% SVR rate, SVR12. Next, interferon-free regimen, SOUND-C2 subanalysis, efficacy of treatment in patients with cirrhosis. This is new protease inhibitor, faldaprevir, non-nucleoside polymerase inhibitor, and riba. This results similar to non-cirrhotic patients in all groups. Look it. However, high rate of discontinuation and SVR12 rates was higher in genotype 1B than genotype 1A in all groups. And finally, results from Aviator study, SVR24 rates with 4 drugs. This is interferon-free regimen, protease inhibitor, non-nucleoside polymerase inhibitor, NS5A inhibitor, and riba. You see no substantial differences in SVR24 rates observed across all subgroups concerning sex, genotype of virus, 1A, 1B, viral load, fibrosis state, and interleukin polymorphism 28B. Evolution of ACV therapy and predictors may be demonstrated on the slide. Looking ahead, during increase of treatment efficacy and resistance to antivirals, simultaneously decrease of role of baseline predictors, including host interleukin 28B genotype, fibrosis state, ACV genotype, and treatment history. In conclusion, actually identification of efficacy predictors for triple therapy with boceprevir and tenofovir is required to achieve optimal results and reduce treatment duration, cost, and useless side effects. Clearly identify genotype 1 Hep C patients, first, who can still benefit from dual therapy, for example, CC genotype, AVIA. Second, who need effective triple therapy, for example, relapses. And third, who should wait more potent drugs, null respondents with no advanced fibrosis. Main baseline and on-treatment efficacy predictors for triple therapy are interleukin 28B genotype, fibrosis state, pattern of previous response to therapy, and decrease in ACV RNA at week 4. And furthermore, in most future trials with DA, the association between the predictors and SVR will be analyzed to identify whether these prognostic factors remain. Thank you so much.